Good afternoon. Welcome back to UCSF Medicine Grand Rounds. I'm Bob Wachter, Chair of the UCSF Department of Medicine. Welcome, as usual, to our live audience in the Department of Medicine throughout UCSF, our colleagues and friends at our partner sites throughout the Bay Area. And as usual, we will post this video onto YouTube tonight at about 7:30 p.m. and I will tweet out the address. Our prior Grand Rounds in this series have been viewed about 350,000 times. A few quick ground rules for the audience are up on the screen. Put your Zoom window in full screen mode. If you have questions, please type them in the Q&A box and we will get to as many as we can. The virus continues to surge through huge swaths of the United States with a particular focus on the South and West. This time feels a little different than it did. We know so much more than we did in March, so there isn't the same sense of panic and uncertainty that was being felt in New York, for example, 3 or 4 months ago. But those emotions have been replaced by something else. I think a combination of disappointment and even a little bit of anger because we do know so much more than we did. And a lot of this feels like it could potentially have been prevented. But we've failed to do that. And the hope is that we will turn things around. For now, hospitals throughout the South and here in California are struggling with larger numbers of patients than we've ever had before, and more patients in hospitals, and sadly more deaths. So in today's Grand Rounds, that's what we will cover, the surges in this phase of the pandemic. We'll begin with a review by George Rutherford on the state of the pandemic, with a particular focus on the areas of the country that are experiencing surges. Then we'll hear brief reports from the fronts, and the 4 fronts that we've chosen are 4 relatively hot spots. Atlanta, Georgia, Miami, Florida, Houston, Texas, and then a report here from UCSF. We are experiencing less of a surge than you'll hear from the other parts of the country, but certainly more than we had experienced before. So let me quickly introduce all the speakers, and then we will start the session. The session will begin with an overview by George. That will go till about 12:25. And then we will bring on the 4 speakers. Each of them will talk briefly about what's happening in their own hospitals, and then we'll bring everybody on for a panel discussion that will go until the end, and the end should be about 1:15 or so. So the speakers are George Rutherford, who now needs almost no introduction. George is professor in our Department of Epidemiology and Biostatistics, and has become a go-to person for us, for the media, and for people really around the country as to the state of the pandemic. We are grateful. The other speakers are Carlos Del Rio. Carlos is Executive Associate Dean for Emory at the Grady Health System and Professor of Medicine in the Division of Infectious Diseases at Emory. He's also Professor of Global Health in the Department of Global Health and a Professor of Epidemiology at the Rollins School of Public Health at Emory. Carlos has a few other titles, but that would take up all of his time, so I won't go through that. He really is an international leader in infection prevention, and public health. Our next speaker is Tanira Ferreira, who is Chief Medical Officer for Inpatient and Acute Care Services at the University of Miami Health System. She's also Assistant Professor in the Division of Pulmonary, Allergy, Critical Care, and Sleep Medicine at the University of Miami. Her work focuses on enhancing academic programs, improving patient outcomes by reducing hospital-acquired conditions, and other work in patient safety. Tanira, we're grateful to you for being here, particularly knowing how busy you are, and you will tell us about that in a few minutes. Rich Robbins is next. Rich is chair of the Department of Medicine at Houston Methodist Hospital and professor of medicine at Weill Cornell College of Cornell University, as well as Houston Methodist. Rich has served on the board of the Pituitary Society and is a recipient of the Distinguished Service Award from that society. He's also on the editorial board of the American Journal of Medicine. Rich, welcome. And again, I'm grateful to you, again, knowing how busy things are down there in Houston. Our last speaker will be our own Adrienne Green. Adrienne is Professor of Medicine and Chief Medical Officer for Adult Services, Vice President for Patient Safety and Accreditation at UCSF. In her role as CMO, she's responsible for ensuring the highest level of care, safety, efficiency, patient-provider outcomes for adult services at UCSF. So Adrienne, grateful as well for you for being on, again, knowing how busy we are here. I'm on the wards myself, and I'm seeing a little slice of it. So let's go ahead and get started with George. We'll review kind of the state of the pandemic, and then we'll bring on the other speakers to hear about what's going on at each of their sites. George, you are on.
Thanks very much, Bob. So let me start off with a kind of a review of what's going on overall. in the United States. And I have a little bit on each of Georgia, Florida, and Texas, and then I'll come back and talk about California and the Bay Area. There have been almost 4 million cases of COVID-19 reported in the United States. Yesterday, there were 71,695 cases reported, along with almost 1,200 deaths. We've had 1,043,495 deaths across the country. So cases are surging through much of the U.S., particularly among states that reopened early. In 40 states, cases have increased in the last 14 days. In only 2 states, Maine and Arizona, which seems to be kind of over its hump and starting to fall, cases been declining for the last 2 weeks. The U.S. is now averaging 70,000 cases a day. And I'll point that this is something important to realize. 70,000 was the total number of cases in Wuhan. So we have 1 Wuhan a day currently, and about 800 cases per day. And you can see down here in the bottom right-hand panel how cases have been trending upwards since early July. The next slide, please. This shows you daily cases per 100, average daily cases per 100,000 over the last week. And you can see, you can look at where Houston, Atlanta, and Miami are. They're part of this great swath that goes across the southeastern United States. That's also, we also see infection up and down the West Coast, Arizona, Idaho, and parts of the other parts of the country. Here in this northwestern corner of Arizona, that represents, or the eastern part of Arizona, that represents probably infection on tribal lands. The epidemic in the West is particularly among the Latinx community, and I think it extends into British Columbia, although they don't quite keep their statistics the same way we do. The next one, please. I think this helps you get a vision of the deaths. You know, when you see these death curves, it has what's been going on in New York, New Jersey, and Connecticut mixed in with deaths from everywhere else. And I think here you can see that here in this last part of July, this upward trend in deaths in the U.S. outside of New York, New Jersey, and Connecticut. I think this shows it a little more clearly. The next one, please. And then this showed up today in the New York Times. I thought this was especially interesting. And this shows you what the hospitalization rates are per 100,000. And again, in the places we'll be talking about, Texas, Georgia, and South Florida, you can see how much greater the hospitalization numbers are than in the rest of the country. And the only thing we have in the West that, well, I guess Los Angeles at 28 comes close to Atlanta or Georgia with 30. But Imperial County at 53 is the only place that has these kinds of big numbers. But I think this is an interesting way to portray it. And again, one of the issues we're dealing with here not only is trying to minimize transmission, but trying to preserve the medical system at the same time. The next one, please. So I'm going to show you Georgia, Florida, and Texas. I don't know why I picked them in that order. But here we are in Georgia. Georgia's had 139,000 cases and 3,200 deaths as of yesterday. And you can see the curve here in the upper right-hand panel, which has been going up since early June with a real upward inflection in mid-June. And it seems maybe to have started to level out here in the last week or so, but at a level of about 3,000 cases per day. There have been 3,264 deaths from COVID in Georgia, with an additional 78 deaths on July 22nd. The mortality rate is somewhere around 30 on average in the state currently, and that's been relatively the same since the peak in mid-April. Here's a map of Georgia for those of you who are unfamiliar with it, Atlanta is in sort of the upper left-hand corner where it says Atlanta. That's a hint. But there's a lot of transmission down in the coastal plains around cities like Augusta and Savannah, and then down on the Florida border and by Vidalia. So that's where the onions come from, by the way, in case people were wondering. So it's it's a mix in Georgia, but it has had a lot of disease and a lot more disease since early June. The next one, please. So remember, 139,000 in Florida. So in Georgia. So 379,000, 3 times more cases in Florida. Those have gone up extraordinarily rapidly since early June, and the deaths have also gone up. There are 5,344 deaths. There were almost 10,000 new cases in Florida yesterday, and 139 new deaths. You can see how that's concentrated. It's quite diffuse across the state, everywhere from the Panhandle to some parts of Central Florida, and then in the Miami, Fort Lauderdale, Palm Beach area. And when we hear from Dr. Vejea later today, she's in Miami and will be speaking about what's going on exactly in Miami. And then next, please. We have Texas, and for those of you so you can see Houston is down in the southeastern corner, sort of, where it says Houston, that's the hint. You can see that there's disease spread pretty widely through the state. There's a large concentration of disease in the lower Rio Grande Valley, in Hidalgo and Cameron counties, which is where Brownsville is, down at the far southern tip across the Rio Grande from Mexico. But you can see it's also up in the Panhandle and getting towards the Big Bend area. Texas has 366,000 cases, roughly same order of magnitude as Florida, with more than 10,000 yesterday and 4,522 deaths with 203 yesterday. So just to kind of give you an idea of what we're talking about here. The next one, please. So now moving on to California, the headline in the Los Angeles Times, right-hand column today was state tops New York in total virus cases. So California has surpassed New York as the state with the most reported cases at 421,889 cases, with added 12,000 yesterday. We've had 8,052 deaths and added 155 yesterday. There appears to be some leveling of mortality at around 90 deaths per day. And you can see there maybe using happy magical thinking, maybe some flattening of the curve up here over the last week in California as well. But for California being number one in cases, we've been third in total cases in the last week after Florida and Texas. We're 12th in cases per capita in the last week. We're 23rd in total cases per capita, and we're 27th in total deaths per capita. So I don't know what's good, and whether this is an accurate scorecard, but I don't know how best to think of these data. But just the crude counts, I think, are somewhat misleading given the size of California. The next one, please. This shows you where transmission is. Since I've been giving these talks, we've progressively seen the Sacramento and San Joaquin valleys fill up. There's tremendous amount of transmission in Southern California, in particular in Orange and Los Angeles counties. In Central California, we see the cases starting from Kern and going all the way up through San Joaquin County. Monterey County, probably owing to the Salinas Valley, is now at this highest level, and it goes all the way up into the Sacramento Valley as far north as Tehama County. And this outlier, this thing that looks like an outlier on the upper right, the northeastern part, is Lassen County, and there's a large prison in Susanville there. So what's going on in California? We have predominantly, as do Washington and Oregon, a Latinx, low-income, densely housed as essential workers and their families who are being infected. They are both in urban as well as rural agricultural areas. A second group are people who have been infected through social gatherings, bars, clubs, those kinds of things, and who are either unwilling or begrudgingly wear masks incorrectly. I'll show you a picture in a second. We all know about the fraternity outbreak at Cal. Whether the fraternity house opened in the summer, I'm a little less clear about. There have been 72 cases now. It turns out yesterday there was a large fraternity house outbreak at the University of Southern California in downtown Los Angeles. And finally, there are institutional settings in prisons, in nursing and other types of long-term care, and in factories. And in fact, there's a large outbreak in something called LA Apparel, a garment factory in South Los Angeles right now that still hasn't kind of played itself out. And then the next one, please. Here we are obeying all the rules in Orange County. At least they're all outside. Let me put it that way. Yeah, that's one good thing. But you can see that it's, I got 1, 2, 3, 4, maybe masks seen in this entire crowd. So this is what the governor sees and says, okay, we got to shut this stuff down, right? So this is the kind of consequences of, that's a cause and effect of this sort of stuff. The next one, please. Oh, this, by the way, was in the New York Times. So just in case you think it was hidden in the Orange County Register. And in the Bay Area, we now have gone past 45,000 cases. We added 103 yesterday. Cases are falling in much of the Bay Area. There's a persistent outbreak in Contra Costa County, largely centered in Richmond. But in the city and in the rest of the counties, it's been falling, with the exception of Solano and Napa. Napa's similar to the other Napa and Sonoma are similar to the other agricultural areas of the state that have had these prolonged outbreaks in the Latinx community. The next one, please. And just to wrap it up, this is an interesting set of data. These are from San Quentin, the state prison on San Francisco Bay and Marin County. Yes, and these do count into the Marin County statistics. While they don't bother to add all these numbers up, if you add them up and you divide by the current population, you come up with 60.11% of the population infected there. And if this had started to return to baseline, I'd say this is where herd immunity is, right? So you have 60% infected. Transmission is slowing down, although it's hardly going away, right? They're still active cases. These are prevalent cases, not incident cases. And this may in fact represent where we do hit herd immunity. So I'm encouraging people who are, if they're interested in looking not at who was infected, but at looking at who was not infected and why they didn't get infected. If they were out getting, with as much exposure as everybody else, then this may really represent where we can draw the line for herd immunity. If they were somehow segregated off into sort of, lower security part of the prison, which has not had an outbreak yet, then all bets are off, and the actual saturation point may be higher. But this may be our best shot right now at trying to understand where herd immunity is. And then the last one, I'll just remind you. This is showing you hospitalizations in California in the left panel, and in the Bay Area in the right panel. We have more patients than ever in California and more ICU patients than ever. And in the Bay Area, we have more patients than ever. And we're about at the same level of ICU utilization that we were in early April. And then finally, I'll remind you that that Anthony Fauci is throwing out the first pitch today for the Washington Nationals, or maybe it's tomorrow. And we have an over-under about whether he throws a strike or not. So if you want to get in the pool, let me know. This is from the Oakland Oaks in 1918. Batter, catcher, and umpire all wearing masks. So I'll stop there and happy to answer questions. Thank you.
Great. Thank you, George. That was really interesting. Let me ask a few questions and we'll move on to the panel. Fewer deaths and less ICU use than in March. First of all, we were seeing a lot fewer deaths a few weeks ago, and it was predicted that we're just waiting for deaths to kick in. Are they kicking in about the proportion you would have expected? And if there are fewer deaths, do we have any sense? Is that treatment effect? Is that younger people effect? Is that change in the strain of the virus effect? One of our questioners asked. So why is the death rate a little bit lower, if it is?
Well, to start with, there is a lag phenomenon, and we have to wait and see. We don't know until we know, right? I suspect the death rate will be lower now, mostly because of improved ICU care. When we get some bump from remdesivir, and get some bump from dexamethasone, and we get some substantial bump from prone positioning for oxygenation. So that's all good news stuff. Yes, they're younger patients, but Monica Gandhi has a very interesting theory. I don't know if she's propounded it here yet.
Yeah, last week she talked
about the mask cutting down on the inoculum size. Yeah. So, and that might actually, I think that's an attractive explanation as well, that people may be getting infected with lower ID50s.
Okay. People have asked about how contact tracing is going, both in the Bay Area and nationally. We made a big deal of it, and you don't hear that much about it. How is it actually working?
Well, in San Francisco, it works great. You should get Mike Reed back to talk about it. There's some they've gone through their data and have a publication pending that I think kind of lays out how many people you can really reach and sort of the ins and outs of it. I think that it's going, basically you have problems with lags in getting test results back. So if you get tested, unless you self-quarantine, the difference between 1 day turnaround and 7 day turnaround is 6 days of wandering around. And so that's, that just creates more contacts and increases the workload and also the risk of transmission. So that's a problem. But for the actual contact tracing case testing, that's at the highest tier of priority for the state. So we get that stuff pretty quickly. I think around the state, there are only a couple of counties with an adequate number of contact tracers. San Francisco and Santa Clara. Los Angeles is kind of at the edge. San Diego's had a pretty robust program. But you need you need a certain number for each new case that comes in. Each new case that comes in takes about an hour to interview, and then every contact takes about a half an hour to interview. So it's, that's the time on the job part of it. So if you have, 8 new cases a day, that means you need 1 case investigator. And if they name 3 contacts that means you need 3 contact investigators. So the calculus is pretty simple. But if you have 1,000 cases a day and you don't have nearly enough, people to do the intake interviews or to find the contacts, that's when it gets away from you really quickly. Yeah. And I think that's the case in much of the rest of the country.
My last question for you is, now we know so much more about how it spreads and the behaviors that are related to spread and how long a surge is likely to last. Are people beginning to model, and do you have a sense of what the fall will be like? Can you expect that the South will cool off the way New York did? And then if so, what might be the next region that gets hammered in the fall, or is that just, there's too much uncertainty there? I
think there's a lot of uncertainty. I mean, the sooner you move inside, the more likely you are to get hammered. And there's been a lot of transmission in the upper Midwest. And I could see that being sort of a next big hotbed. Out here, it's where, I mean, it's gonna take sort of a very different approach here with the infection relatively circumscribed in certain geographical areas. I just got off the phone with San Mateo County before I came here. There are infections in like 2 communities, in the whole county, and they're going to set up pop-up testing and do better isolation and quarantine and all those kind of disease control things. So,
yeah. And is New York with 15% or 20% antibodies, are they relatively protected from another surge?
No, that's not. I mean, as San Quentin tells us, you need 60%, right?
Yeah.
And that hasn't stopped yet. By the way, Spain is starting to get new cases. Their curve's starting to go up again.
Yeah.
So just because you've had one big surge doesn't mean you're protected.
Got it. All right, George, thank you so much. As always, grateful to you for making sense of a lot of complex numbers and trends. Really appreciate it. Let's move on to our next group, and we'll hear from each of our 4 speakers, basically giving reports from the front. The first front we will hear about, particularly personally interested, because I have a son and daughter-in-law who live in Atlanta, is hearing about what's going on in Atlanta at Emory from Carlos Del Rio. So Carlos, you're on.
Thank you, I'm delighted to be on. Can I have the next slide, please? So here you can see 2 graphs worth looking at. One is New York, where you can see it peaked early and then it's come down. And then you can see Georgia right next to it. And you can put all the other states we're talking about. You can see Florida, Texas, but I wanted to highlight here Georgia. And you can see how different the 2 epidemics are and how really in this country, we don't have one epidemic, but we have multiple epidemics. The next one, please. So I'm trying to summarize here some of the things that have happened in Georgia. And basically in Georgia, the governor closed the state late and opened the state early. And here you can see, in fact, working with the mayor, I was able to get a resolution to close the city of Atlanta about 10 days before the governor finally decided to shut down the state. But that wasn't until really late March, early April that he did. And then soon thereafter, he opened the state back up, worried about the economy. And here we are, obviously, me and the governor have had this ongoing debate. He says it's about, it's about keeping a healthy economy. I keep on saying that the way to get a healthy economy is through public health. And I think we see here this debate happening over and over. The next one, please. So I'm showing this because this was one of the arguments that the governor's staff used to opening the state. They said, well, cases are coming down, so now we don't need to worry and we can open the state. But in fact, this really was due to the fact that cases were not reported and they were using epidemiology in a way that shouldn't be used. The next one, giving epidemiology to people that don't know how to use it leads to problems. And here's a cartoon by Mike Lukovich, who's a very well political cartoonist here, who's showing exactly what happened. Simply, this is the cases in Georgia, and the monkey fell off the ladder, right? The Department of Public Health started making up stuff, and by showing the data before it was complete, they were able to say, well, now we have the evidence to say that we can do this. So they did really use pseudoscience to do this. The next one. But there were clear evidence that we weren't ready. In the New York Times, this article about why Georgia is not ready to open this quickly. And here's why Georgia was vulnerable. We hadn't met the targets of a downward trajectory. We had 16% uninsured, which is the 4th highest in the US. 13% of Georgians had diabetes. We ranked 15 in the share of adults with heart disease, a large population at risk. And we had already had super spread events. So obviously the evidence was very clear that this was the wrong thing to do. The next one. And it was, and it just, sometime happened. And I think, when the state opened, most people stayed indoors, but it was really around Memorial Day that people started going out, and primarily young people started going out. And this led to this increase in cases that you're seeing here in the graph to your upper left. We are beginning to see maybe a little stabilization. I'm not sure that's true. Deaths have continued to come down, but they have again begun to stabilize. And we're really seeing a huge uptick in hospitalizations. The next one, please. And in fact, you can see the data where we are in Georgia right now. We are having, 28.1 cases per 100,000 population. Our positivity rate in our PCR test is 15%. Our ICUs are saturated at 97%. And Bob, you were asking about contact tracing. Contact tracing essentially is not happening. Only 8% of contacts are being traced. So contact tracing is great in theory, simply not happening. The next one. This is from the famous White House report that was leaked out. And this is the White House report showing that Georgia has 94 counties that are in the red, many cities. The next one. And as you can see, we're again seeing a lot of the evidence. This is multiple counties going up. Many of the counties are here in Atlanta, like Gwinnett, DeKalb, Fulton County. The next one. And the recommendations from the White House Coronavirus Task Force are not a mystery. They are about to wear masks. They're about to limit gatherings to 10 people or less. They're about closing bars, nightclubs, and you can read them on and on. But basically, many of the things that will stop the spread of this virus. The next one. This is the dashboard for the city of Atlanta. And again, you can see here where we are and how the cases are going up. The next one. And how in our hospitals here in Atlanta, this was in March, we never reached 800 hospitalizations. Right now, we're over 1,300 patients hospitalized. ICUs have also begun to be above where they were in the past, and we are having now over 400 people in ICUs. The next one. Now, this has been a different epidemic. You can see in March and April, the age of the patients was older. The age of the patients now is about a decade younger than it was before. The next one. But in the meantime, the mayor has closed the city of Atlanta again, has ordered masks, but the governor has actually sued the mayor, so this doesn't go through. So part of the problems we're having is this challenge between politicians playing politics instead of playing public health and trying to protect the public. The next one. I think that's the last one. So where are we right now? We're obviously in a very difficult situation. The hospitals are, and we tripled our hospital capacity in less than 3 weeks. We are trying to cope with that. I think we can convert more areas to ICUs and to hospital beds. I think we can, get more stuff, more PPE, et cetera. But the problem is staff. You cannot make nurses, you cannot make physicians and APPs out of nothing. And staff, I think, is a great limiting factor in dealing with this surge. And with that, I'll end. Thank you.
Great. Thank you, Carlos. Scary, thank you. Let's move to the next area of the country where I also have relatives. I have 90 and 84-year-old parents in Boca Raton who basically are in solitary confinement. So concerned about Miami for many reasons. Tanira, tell us about what you're seeing there.
Sure, very well. Thank you for having me. Good afternoon, everyone. I think I echo my colleagues that spoke before. I think what we're seeing is a regional variation within the state, and within the state, you're going back to the cities, and even the cities within the zip codes within the cities, we're seeing a variation. And that, interesting enough, affect the health systems within town in a different fashion. Yes, we're short on ICU beds and hospital capacity, but what has changed now this time in comparison to the first time around? Certainly, we're better prepared. We know how best to take care of these patients. Yes, remdesivir, dexamethasone, proning. There's over 40 ICU protocols that we have implemented. But I think one of the things that we very early on this pandemic, our preparation, at least at the University of Miami, we had made a conscious decision that we're going to separate the hospital in two. We're going to create a COVID wing and a non-COVID wing. And we created a concept of vertical isolation that still to date, that's what we implemented back in February. That's when we started. And then in March, we continue to do on that. And we obviously screen all the patients. And we created negative pressure rooms in the upper parts of the hospital. And then we start going down. So the University of Miami Hospital is 450 beds. And we literally broke the hospital in two. And along with that, with this vertical isolation concept, also we sort of repurposed staffing for COVID versus non-COVID, and for a variety of infection control reasons. I think it did work. And this is, just to give you a perspective, 4 weeks ago, we had 5 COVID patients within the hospital. Today, I have 156 COVIDs with the hospital, and of those, 38 are in the ICU, of which 30 are intubated. So you can see that there's a significant, increase in the number of patients. And as Dr. Del Rio was mentioning, this coincides exactly when the city was open, which was 14 days after Memorial Day. I also work very closely with the mayor in terms of working with the plans. And I think fundamentally what happened here in Miami and in many parts of the country, people simply did not adhere. And there was not a unified force to sort of speak to what's the right thing to do. There's not enforcement of universal mask wearing, social distancing, the gatherings, stay home if you're sick, and so forth. So the consequence today, and what I want to mention to this group is, when we talk about staffing, which Dr. DeRue started mentioning, yeah, we're certainly seeing a lack of staff in terms of nursing, but also medical personnel. But we're able sort of to flex and run a COVID versus a non-COVID hospital and flex the elective procedures versus the less urgent. We really had to sort of put the brakes without formally announcing we stopped elective procedures, but we sort of decreased substantially that number to free up either CRNAs or nurse practitioners to help pair up with the intensivists. Obviously, there's no unlimited number of intensivists. We cover here and we cover Jackson Memorial Hospital, which is another 1,500 beds. They have a little different setting, but it's also the same faculty that covers both sides of the street. So what we have done here, for the COVID ICUs, we paired up the intensivist along with an internist. We sort of trained certain group of internists to be able to sort of round on those patients, do the basic care, but obviously in consultation with the intensivist, along with the fellow or an APRN or a CRNA. So we created sort of teams of intensivists that the intensivist will be on the top, overseeing 2 or 3 internists, and those internists having a less amount of patients. And with that, we're able to flex and not really stop operations in terms of elective procedures and able to sort of repurpose personnel. But the fascination is that whatever has been described by Dr. Rutherford and then by Dr. DeRue is exactly the same situation, but in different stages. So our projections from this time on, pretty much there is a slight decrease in the number of cases. The positive conversion rate of cases in Dade, Miami-Dade, had peaked last week at 33%. We're down to 18%. And the number of ICU beds that were over 115% capacity, now we're actually have 12% beds still available for ICU. So we've seen a slight decrease. Yet the mortality seems to be decreasing in comparison to before, but I think it's too early to tell because we have a lot of patients still in the ICU and a lot of patients intubated. But thank you so much for having me. And this is sort of a summary in 5 minutes, what's happening here.
Perfect. Thank you so much. Tanir, how do you compare to other parts of Florida? Is Miami one of the worst places or sort of in the middle?
In terms of the cases you mentioned?
Yeah, just the overall surge, the flavor.
Oh yeah, the overall surge in Miami is simply quadruple the number of cases. And as a matter of fact, our sister counties, including Broward and Palm Beach, Miami-Dade by far has been the worst. And it's the problem because it's overwhelming some of their systems there because some of the patients are traveling to those areas for them to get care.
Got it.
So, yes.
All right. Thank you. Let's bring on Rich to hear about what's happening in Houston and at his hospital, Houston Methodist, which is a very big hospital in Houston.
Houston Methodist Hospital is at the Texas Medical Center. And the Texas Medical Center actually has 14 hospitals on the same campus. Next slide, please. So since early March at our hospital system, Houston Methodist has 6 other hospitals in the greater Houston area. We've, through all of our hospitals, we've tested about 50,000 patients and we've had 13,000 positive test results. Of those, about 4,200 of those have been hospitalized in our hospital system. And we currently have just over 700 inpatients at the moment. We've discharged 3,200, and we've had about 260 deaths since that time. Next slide. So this is a little time course of the cases. And as you can see, back in early April, when New York City was the hot spot, we also had a rise in cases at Houston Methodist. And you can see that, interestingly, at the time, in the dark orange is the number of patients on mid-surge floors, and the light orange is the patients in the ICUs. You can see back in early April, it was about 1 to 1. For every patient on the general floor, there was 1 in the ICU. We then got a little reprieve during May when we thought everything was fine, but then we got hit with a tsunami in early June. But this time, as others have shown, although the total number has gone up quite a bit in the mid-surge floors, the number in the ICUs has lagged behind that. And over the last week, 3 or 4 days now, we're starting to see a steady decline in the number of new patients coming in, but the number in the ICUs is slowly going up. Next slide. So I just wanted to highlight a few of the governmental and societal events that have happened during this time. And in early April, as we started to see cases, the Harris County judge issued a stay-at-home order. And then finally, the governor issued a statewide stay-at-home order. The cases continued to rise. And under pressure from national leaders, our governor decided to start easing restrictions around the middle of April, when we still had quite a few patients coming in. As we started to decline in early May, the governor did a three-phase reopening of the economy to get the businesses back. And in early May, recommended opening of retail and restaurants at a 25% occupancy level. Then he also opened barbershops, massage parlors, nail and hair salons. And in the end of May, phase 2 reopening happened, where up to 50% of restaurants and other businesses could get up to 50% capacity. Then Memorial Day hit, and the brutal murder of George Floyd happened. George Floyd's funeral was about 4 miles from our hospital here, and there were large protests all over the country that may have had some impact on this. But even though our cases were rising, our governor moved on to phase 3, at which time bars could have up to 50% occupancy, restaurants could have 75% occupancy, and more people were coming out without masks. Then, as you can see, in early June, things started going up. By the middle of June, the Harris County judge ordered masks for everyone. Then we started closing bars and restaurants near the end of June. Then there was a statewide order in early July by the governor that everyone in Texas, wherever you were, if you went outside, you should have a mask on. But despite that, the numbers continue to rise. And you can see for over the last week to 10 days, we've been at a plateau in our hospital system where we've had about 700 patients in the hospital. Next slide. Our testing rate, you can see, has undergone several peaks in early April. Our most recent testing positivity rate now in Houston Methodist, where we can do up to 10,000 tests per day, was 25% a few days ago and has declined down to around 22% today. Next slide. This just shows you a little bit about the demographics, and you can see in the top graph there that the median age of the patients that we've admitted to the hospital so far has been around 60. You can see in the little diamonds the mortality rate for each one of the age groups. Basically, we've only had 2 mortalities in people under the age of 40, and that it really starts to shoot up in the 70 and 80-year-old age range. In the lower right-hand corner, you can see that it's gender neutral, affects men and women equally in our part of the country. And as far as a racial breakdown, in the greater Houston area, about 50% of the residents are Caucasian or white, and about 61% of our admitted patients, COVID patients, were Caucasian. In Houston, about 26% of all the residents are Black or African American, and you can see around 27% of the patients who we admitted were in that racial category. You can also see that, I don't know if you can see it here, but the mortality rate in Caucasians was about 6.9%. The mortality rate in Blacks and African Americans was about 6.2%. Asians made up about 5% of the admitted, but their mortality rate unexpectedly was almost near 10%. Next slide. This gives you a little snapshot in the last week or 4 to 5 weeks of what's going on in our hospital. And one of the things we've clearly seen is a shift downward in the age of our patients. From 60, it's now down to around 45 is the mean age. The mortality rate in each age group, though, has pretty much stayed the same, despite the fact that there are many younger people now being admitted. And the next slide. And we've taken this opportunity. Many of our younger faculty members in pulmonary, infectious disease, and critical care have now come to the front and have started investigator-initiated and have served as principal investigators on many different clinical trials. The first 3 have now closed. Our convalescent plasma protocol enrolled about 350 patients over the past 3 months. We currently have 7 open and enrolling trials hitting various targets. And we've just started in the past 2 weeks with monoclonal antibodies from both Regeneron and Eli Lilly. We also have 6 more clinical trials just about approved by the IRB, and we'll be ramping them up and activating them in the next 4 weeks. So it's been quite a rapid event, taking our breath away. But we're slightly hopeful that in the last 3 or 4 days, we're starting to see a little bit of a relief, and we hope we're on a downhill trajectory over the next several weeks. So that's a quick report from Houston.
Great, thank you. You mentioned there's 700 patients in the hospital, Rich. So what percentage of that? How many beds do you have?
We have at our main medical center, our main hospital, we have a 900-bed hospital, and just at the main mothership, we have about 250 patients out of the 900 that are COVID patients.
So almost a third of the patients in the building are now. And have you stopped elective surgeries, or how have you created capacity for 250 new patients?
Back in April, we did suspend elective surgeries for about a month. But this time around, following the governor's guidelines, we were able to keep elective surgeries going. But we've converted many of our intermediate medical step-down units and our neuro ICU, we've converted into a medical ICU. So we've also brought on extra beds and created ICUs with staff. But as somebody mentioned before, it's not the beds, it's the staff that take care of the patients. And unfortunately, we've had a number of our nursing staff and medical staff come down with COVID and have to be quarantined. So I've spent the last few weeks calling around the country to get telemedicine experts to phone in or tele in to try to help take care of our patients.
Wow, great, thank you. Adrian, actually, before you start telling us about things at UCSF, I'd love to hear your reaction when you hear the kinds of numbers you've just heard from these other institutions. And then go ahead, tell us what's happening here.
Absolutely. So these numbers, and particularly, when Tanira described that just very acute rise in patients in the short term, it's scary. And I think what I was going to talk a little bit about was that, while we have just been watching the rest of the country with these scary numbers and have been watching the scary rise in California cases, we've been very protected in San Francisco. Even now, as I'll show you, our numbers are on the lower side. And while we've done a lot of work related to surge planning, which I'll describe to you, it still has me, having restless nights to think about this. And I think we're prepared, but this gives me a bit of pause. So as I mentioned, we haven't had, next slide please, we haven't had a surge in San Francisco of the magnitude that others have experienced. And I'm so humbled by what others have just shared. And because I imagine that many of the folks in the Grand Rounds audience haven't ever been involved in surge planning, I thought I would just briefly share with you our surge planning journey and a little bit of a surge planning 101, so you know how we're thinking about things should we have a significant surge, as has just been described in San Francisco and at UCSF. And then I'll end by sharing the current state of the numbers at UCSF. Next slide, please. When we started planning back in February and March, we used sort of basic surge planning principles, which called to address things like space, staff, stuff, and systems. We planned in the context of what we were hearing from many local, state, and federal agencies in addition to collaborating and looking for ways to standardize across the UC system. And fortunately, we weren't completely starting from scratch, as we have had surge planning related to our always very high capacity. And we've had experience with emergency management planning related to our recent labor actions and emergencies like the fall wildfires. Next slide, please. So on March 6th, we held a very large multidisciplinary health system-wide meeting, which I'm embarrassed to say now that met in person to develop a comprehensive plan that addressed everything from capacity to workforce to care protocols and supplies. And before that meeting, we read everything we could get our hands on. We consulted colleagues who were ahead of us in this journey, as we've just heard. And we had this amazing learning session with some colleagues from Singapore who had had very great success in their related to SARS as well as their early COVID experience. And the principles we set out were to identify triggers and required actions to assure capacity and safe care for COVID patients. We wanted to be sure that we could assure the safety of our healthcare workers and our non-COVID patients. And as people have spoken about, we really wanted to maintain our workforce. And with this early experience, we learned a ton. We opened a variety of dedicated units. We implemented many different PPE and clinical care guidelines. And ultimately, in our sort of first wave of cases at UCSF, we had a census peak of 23 in early April. And then that census dipped down to 6 in early June. And our curves look very similar to many that you have seen, just with a very different magnitude. So we took that opportunity to rethink our planning with particular attention to the fact that the ramp down and the empty hospital was not going to be a solution for the long term. We really needed to be able to manage both COVID and non-COVID patients in what I sort of like to call a coexistence model. So we rewrote our plan with a goal of simplifying our triggers, learning from our actual experience, taking advantage of the new beds that we were able to open at Mount Zion, and then most importantly, really improve the balance between the care of our non-COVID patients and their needs and our COVID response. Next slide, please. So for those who are more visual, we've evolved from this very complex and conservative algorithm to one in which we simply look at the number of hospitalized patients with COVID, and we report that side by side with our capacity surge level. And as an example, today we are yellow for COVID and orange for capacity. Next slide, please. So I know that you can't read this, but I wanted to share that for each level of surge, we have this very, very detailed system-wide consolidated plan, and then we have an individual targeted plan for every entity and functional area in the health system. If we sort of link back to those 4 S's of surge planning, you can sort of see across the top that we address space in the capacity column, we address stuff in the PPE column, staff in the occupational health and workforce column, and so on. Next slide, please. So with that is a little bit of background about our planning. Where are we today? So this is our executive COVID dashboard. For those who are watching who haven't seen this before, you can access it through the link that's on the slide. You can also access through care links as well as a COVID link that is in Apex. We review this very closely each day. We also look at a lot of the publicly reported data that George shared so that we know what's going on in terms of trends both in San Francisco and the larger Bay Area. Today we have 31 COVID-19 patients in beds across all of our hospitals, both adult and pediatric. Our new peak census was 33 about a week ago. And we have actually had the highest number of cases of the San Francisco hospitals in what I like to call the sort of second wave of the first surge. In that first wave back in April, ZSFG had the higher number of cases. As with today, typically we have about 50% of our patients in acute care and 50% in critical care. About a third of our patients have been transferred to us from smaller hospitals throughout the Bay Area and Northern California. Most of those patients have tertiary and quaternary needs in addition to their COVID-19. We have of these 31 patients, length of stay ranges right now anywhere from 1 day up to 30 days. I believe our longest length of stay patient was, I believe, like 68 days. And we have had 12 deaths at UCSF for a mortality rate of almost 7%. And then lastly, I just wanted to quickly mention that we've had 3 mutual aid transfers up from Imperial County. We also took 5 patients from the San Quentin outbreak. All of those patients have now been discharged. Next slide, please. And then lastly, while I believe we're prepared for a surge with all of this planning, if you were asked to ask me sort of what keeps me up at night related to our surge planning and our overall preparedness, it would be sort of how we manage this fine balance between having capacity for this next incremental increase in COVID-19 patients, whatever that might be related to this more recent surge or one that might come in the fall, and continuing to be able to serve our very sick, complicated, non-COVID patients. So we're starting to do a bit more work to think about how we can level load across the city so that we can preserve our ability to care for these sort of complicated tertiary quaternary patients. And then related to a surge, we always worry about supplies, everything from PPE to pharmaceuticals like remdesivir and dexamethasone. And then more recently, testing reagents have been of significant concern from an allocation standpoint. And then as others have emphasized, I will emphasize as well, staffing and our workforce remain a concern. And I would be completely remiss if I didn't put in a plug for masking and distancing in order to sort of prevent both the community and work-related exposures that would really impact our workforce. And with that, I will conclude and look forward to the discussion.
Great, thank you. Thank you very much. So let's bring everybody on. And love to hear from, particularly from Carlos and Rich and Tanir, sort of what is the ambient environment around your health systems in terms of are restaurants open, bars open, are people wearing masks or not, and how are people kind of reacting to the surges? Do they kind of understand the problem, or has this thing been politicized up the yin yang and everybody's chosen their teams? Carlos, you want to start with that?
I mean, I think it depends where you are, right? You can be in areas of the city where you see increasingly masks being used. I think what you're seeing also is in the absence of a state mandate, I think businesses are taking the initiative and businesses are creating the mandates. But let's not forget that that's putting an undue burden on businesses. For example, today, Delta kicked off a fair number of passengers off their plane for not wearing a mask, but there's no FAA mandate to wear a mask. I mean, there's an FAA mandate to have a seatbelt, but not to wear a mask. So we really need mandates at the federal, state, and the local level, because otherwise you have a patchwork of decisions, and when you leave it up to businesses that shouldn't be doing this, and quite frankly, then everybody does whatever they feel like it. And, I was also with some people today who are saying, well, yeah, the mayor says we need to close, but the governor says we can, so therefore we should just go ahead and open this business. And I was like, wait a second, no, let's follow the data, let's follow the science. So I'm concerned that we're not taking this virus serious enough. And using my HIV analogy, the viral load in the community is way too high to be doing any opening at this point in time. We really have to bring the viral load in the community down before we can start talking about opening schools and opening businesses and anything like that.
Yeah, thank you. Tanira, what's going on in Miami?
Very similar situation. I mean, we too have been advocating along with the mayor. The problem is we don't have a unified force, as Carlos just said. I mean, we met with the governor and we really wanted a mandate at the level of the counties for the state, quite frankly, for universal mask usage, and we couldn't get it. We got the mayor, though, to accept the universal mandate of mask usage, which was a big thing. The business are willing to work with you, and the plans, we wrote the plans along with the mayor to open the city, and it goes in phases, as you know, based on the conversion rate and so forth. But what it is, the people are not adhering. The business are willing to work with you, but the behaviors of the people, they're just not following. So the current state is restaurants are open only for outside dining. The beaches are open, and majority of the business are open. And I don't think it's going to open any further until we see the situation controlled.
What do you think, what's going to happen with schools there?
Well, that's another big talk. I think half of the county is going to go probably virtual for now. And we need to see the conversion rate for positive less than 10%. And we're like last week at 33, 2 days ago we're 22, and today we're at 18. So I think we're still far from that. So there's still a lot of talk.
Okay, Rich, what's happening in Houston?
Yes, well, for the last 150 years, Texans have had an independent streak. So many of them are not so happy to follow the rules that are laid down. But in his defense, the governor about 2 weeks ago put out a statewide mandate to wear a mask anywhere when you're outside. They've also turned back the phase of opening, and we've gone back to cutting down the number of people who can be in a bar or a restaurant at any one time. So we've downshifted and gone back, and I thank the governor for doing that. But still, there are many young people who feel, they're immune from everything, and they're out partying. So I think it's very much like Florida and Georgia. It's hard to get everybody. The problem is if only 20% of the people are not following the rules, that ruins it for everyone else who is following the rules.
Yeah.
So we have messages, we put messages in our newspapers, we've taken out TV ads to try to encourage people to understand this is not a hoax, this is a real thing, people are dying, and you really need to toe the line.
Yeah. Are you seeing patients come in who said, I thought it was a hoax and I didn't really believe this was real?
We've had patients come in who actually passed away and said, gee, I thought this was a hoax. Now I understand it's real. It's very sad.
That is very sad. Adrian, everybody who's watching now probably is in San Francisco or the Bay Area, but we'll have another 10 or 20,000 people watch on YouTube. So you just give a sense of what life in the Bay Area is like as it pertains to COVID risk, masking in the schools and things like that.
Yeah, absolutely. So, I think that, San Francisco, for the most part, is a bit of a bubble. As we walk around, most people are wearing masks and are, appropriately distanced in line to go into stores and whatnot. We remain largely closed to things other than sort of the larger, grocery stores, et cetera, outdoor dining only. That said, I think that what we're starting to see is more and more gatherings, particularly 4th of July weekend, Memorial Day weekend, where there were sort of more people on the beaches, even with the parking lots closed. People sort of parked far away, and you could see them with these big backpacks sort of walking in if you happen to be driving by or biking by. So I think people are restless, but overall, I think a bit more conservative than what we're hearing from the rest of the country. That said, I think we still hear stories such as the one that Rich just presented of people who, went out on the 4th of July and, ended up with COVID and a potentially bad outcome.
Yeah, I just noticed on the dashboard, which by the way is just spectacular. The folks who put it together really are to be commended. We've had, I think, 5 deaths. We were stable at 7 deaths for almost seemed like weeks and weeks, and then we've had 5 deaths in the last several days. A little surprising given the therapies, which at least the data shows that they should reduce mortality significantly. Is that a blip, or do you think there's something going on there?
I think that some of this is in patients who were here for quite a while, as well as, many of the deaths that we have had are in patients who have just very significant comorbidities in addition to their COVID. So, one of our patients actually probably died from, a CNS tumor as opposed to the COVID. So we're seeing a little bit of both COVID and the comorbidities really at play.
Yeah. So I'd love to ask all the rest of you, because Adrian sort of touched on this, we had 3 months to prepare. As you thought about life in June, let's say, did you think that it was going to be possible that you'd be getting hammered the way you are now? And to the extent that you had prepared, because we all got to watch New York, what did you get right and did you get anything wrong? Is there something that you sort of, even though you theoretically are preparing, you just cannot prepare for what you ultimately see when it's real. Tanir, do you want to start with that? Sort of.
Glad to. Well,
Yeah.
actually, we're very fortunate because we prepare every year for hurricanes. So we have an emergency management system activated actually end of January. That's when we're preparedness. We start acquiring medications, propofol, a lot of sedatives, ventilators, PPE, you name it. We got it together with our command center. And as I said, we made a conscious decision to flip the hospital in two and create negative pressure rooms that we're going to maintain those rooms and flex those beds for other types of cases in case we're not using for COVID. So we're very fortunate that the preparedness was there, and we had a chance to prepare by watching what happened in China, then New York, Seattle, and so forth. And what we could have done differently, well, what I didn't expect to see is what we're experiencing now this early. We're preparing for this probably for September and October. But the thing is, we never stop preparing because the plans were in place. We just sort of adapt the plan and surge as it required. But everybody's exhausted. We haven't had vacation. Our faculty is not able to travel. Everybody has a mandate and is on standby to work. And it's just exhausting. The same for the nurses and RTs.
Yeah.
I don't know what I would have done different except for asking for a unified voice at the level of the governor without getting political. But it has to come from above and mandate people to follow the rules based on science.
Yeah. And then in terms of your workforce, and somebody asked about trainees, as you've cohorted the patients, what can trainees do and what don't they do in terms of the care of the COVID patients?
They're doing a lot. The medical students are not allowed to interact with COVID, but the residents and fellows, there certainly are. And that goes across not only here, but at Jackson, because we cross-cover. So they're part of the plan. They're part of the search plan. So.
Okay. Carlos, what's happening at Emory? Sort of maybe take it from the start, sort of what did you think might happen? Did you expect anything like this? And what did you get right in your preparation? What did you not anticipate?
So March was hard because even though we had time to prepare, it kind of hit us very quickly, right? And we were struggling. We were trying to acquire PPE. We're doing this. I think after we settled things down and we figured what we needed to do, then we, as has been said, we have continued preparing, and we were thinking we were preparing for the fall, not for right now. But I think like most people, we were, stocking PPE, and we had plans and we're ready to have this increase. I think the major issues, and we're doing fine. We're at capacity, but we're handling. I think the major issues that I worry about, Bob, is again, I go back to staff. The staff are tired. They are, the first time in March, April, it was the adrenaline rush. It was the excitement. It was something new. There were, people in the streets greeting, applauding and clapping for healthcare providers and heroes. Right now, people are tired. People are exhausted. People are frustrated. People are saying this should not have happened. We could have done better. And I think that's what you have. You really have, I think, a mental health crisis among providers that I think we need to address. And I think we are addressing here. Our psychiatry department is very involved, but that still doesn't mean that it doesn't happen. So what you see is, all of a sudden, let's say, a phlebotomist calls in sick, and somehow she is found to be infected, and somehow rapidly all the other phlebotomists call in sick. So you have all of a sudden you don't have one vacancy, but you have 5, right? And I think the personnel are really tired, are really fatigued, and they're getting infected outside. So I tell people the safest place to be right now is the hospital. It's the community where you don't want to be, because we're actually protecting you here in the hospital, but it's out in the community that people are seeing all over the place things. So I worry about how we're going to be, in 6 weeks or in 8 weeks if this were to continue, because at some point in time, people are going to say, I've had it, I can't continue doing this. This is way too hard. And we have to think about how do we take care of our people, because this is our most valuable asset, quite frankly. And we focus a lot on stuff and not enough on staff.
And how much nosocomial transmission? Someone asked, how much have you actually seen?
And we actually saw at the beginning, we saw a little bit. We actually have seen almost nothing, literally. I mean, nosocomial transmission, we've gone through universal masking, we've gone through universal eye protection before CDC put those guidelines. We mask all the patients. We're really not seeing any of that. As I said, the transmission is in the community. When we saw it happening is, let's say, a group of physicians or a group of nurses or a group of residents, would get together in that room and eat together or go out together. But it was in non-patient care areas where they would have had transmission. So we have gone to, universal masking no matter where you are in the hospital. And I'm sorry, but
Yeah.
you can't eat, social events have gone away, basically.
Yes, yes. I have to ask you, you brought up the CDC, Emory and the CDC work hand in glove, and been a lot of criticism of not so much of the CDC, but of the forces being brought to bear on the CDC. Sort of what's your sense of what's going on within CDC?
CDC is filled with fantastic people. They're my colleagues, they're my friends. It has been very unfortunate to see how CDC has been sidelined in this pandemic. Without a strong CDC at the front and center, we're not going to get out of this. You really need to give CDC the resources and the independence it needs in order to do what they need to do. But as long as CDC puts out a guideline of what to do in schools, and then the White House says, I don't like it, you need to change it, we're just not going to be where we need to be. There needs to be no political interference in order to get out of this. And the fact that CDC has been sidelined and has been so ineffective and many of us here in town really find it incredibly frustrating and quite frank sad.
Yeah, and I assume people are demoralized, but what are you hearing from your colleagues inside?
The colleagues inside are, quite frankly, they're soldiers, they're public health professionals, they're trying to do the best they can in the conditions they are. I'm really amazed that they haven't all quit en masse and just left. And they're doing it because they actually care about public health and they care about the country.
Yeah, thank you. Rich, what surprised you about this? What were you prepared for, and what did you get wrong?
Well, when we were back in early April, when the hotspot was New York City, it was worth our while to take a look at the history of the pandemic 100 years ago, because our wave looks almost exactly like it did 100 years ago. There was a small pre-wave. The second wave was 4 times higher than the first, which is almost exactly what we've seen in Houston. So back in April, we really bumped up our supply chain to really focus on stocking up on PPE. And we took advantage of our engineering medical school that we have about 60 students here who are all engineers in medical school to come up with all kinds of devices, a way to recycle PPE, a way to make creative extensions of the stuff that we use to make it even better. But one of the most important things that I think happened, as I said before, there's about 14 hospitals at the Texas Medical Center, but there's 7 very large hospitals. And for the first time, the CEOs and the executive vice presidents of all those hospitals actually got together and have daily meetings and work together to make sure that if somebody doesn't have ICU beds, the other one can help out. We can transfer patients back and forth. So it was an extraordinary pulling together of the leaders of many large hospitals to try to work in concert. So that was a great thing that's come out of this.
And do these hospitals generally sort of play okay together, or they actually compete against each other, even that they're all next door in the same complex? But what's the normal relationship?
The normal relationship is they're trying to steal patients from each other all the time. But on the other hand, there's very good collaboration when it comes to education or research. But when it comes to market share, it's a dog-eat-dog fight.
Yeah. And if anyone has never been to the Texas Medical Center, it's the most awesome, truly awesome thing. It's like the first time you see the Pentagon, you can't believe the size of it. It's truly, it's extraordinary. Let me go around like one last time and see if anybody has any final parting words or thoughts that they have that they want to share that we haven't gotten to. Carlos, do you want to start? Anything?
No, I would just say that this is the challenge of our lifetime. This is an opportunity to rethink. We didn't really talk much about how we have done things like telemedicine and other things. It's a great opportunity to redesign healthcare and how we do it. I think it's a good opportunity to think about more efficient models of care and how do we do more outpatient care and telemedicine and other things. But I also think it's a great opportunity to think about how we do research. And we're learning a lot in the research arena about how to do remote consenting, iPad visits with research participants, things that we never thought about. So let's use this challenge as an opportunity to really rethink a lot of the things that we've done in very sort of old-fashioned ways for many, many years, and really think about, medical education. There's so many things that we can actually use creativity to really use the pandemic as an opportunity to do very unique things. So in my mind, it's a challenge, but it's also a unique opportunity to really transform our healthcare system. And
you're sort of our main public health expert here, and maybe George may come back on in a sec. you hear about, okay, we will learn our lesson from this thing and we will be prepared for the next one, and the public health system will get the funding it's been starved of for the last blankety blank years. When you hear that, do you buy it or your BS detector goes off?
My BS detector goes off. I mean, it's going to depend on what the politicians do. The reality is we have underfunded public health for many, many years, and now we're paying the consequences. Bill Foege, who's one of my heroes, has a saying that he stole from Dolly Parton that I love. And he says, that Dolly Parton used to say, you have no idea how expensive it is to look this cheap. We were very cheap in public health, and now it's costing us a fortune, right? And I think that's the lesson we need to get across. It's not what we spend then, but what we're spending now. So we have to be advocates for public health, and we have to be advocates for really having the right funding in place so this doesn't happen again. But I'm very concerned that will not be the case, because simply priorities will shift very quickly.
Yeah, that tends to be what happens. Tanira, what are the take homes that you'd like to leave people with?
Look, I think it's been a great opportunity for us to continue to partner with governmental agencies and local governors for us to continue to advocate for the right thing based on science. But I think we're going to face similar things unless, how can the medical community overall really unify and have a one voice without pros and cons? We saw a lot of things. First, hydroxychloroquine, then no hydroxychloroquine. Even within the medical community, it took a while for us to get our arms around which are the trials, which are the ones that are proven effective. And actually the media sort of took that and made us completely discredit among the community. And that's why it's so hard for us to have a unified voice for people to adhere for what's right. So I don't know how to make it better, but.
Yeah, but I mean, as I hear that, it's that part of the lack of unified voice was that's what science looks like. It took us a while to sort out some of the meds and masks and all that. The part that bothers me is the lack of a unified voice in the political arena and also the people. I mean, we're hearing a lot of examples of behavior on the part of individuals that could be different and would make a huge difference if people followed the rules.
Agree.
Yeah. Rich, what are your thoughts?
So I had many of the similar ideas that Carlos had. I think one thing that's going to transform medicine going forward permanently is the incorporation of telemedicine technology in how we take care of patients both in the hospital and in the office setting. I think electronic medical records syncing up with remote care and e-consults are going to become a standard element as we go forward. Whereas just a year ago, people were kind of tiptoeing around the whole idea. So I think that's going to have a rapid incorporation. Secondly, I'm really encouraged by how this stress test on all of us has lit a fire under our junior faculty to get more involved in clinical investigation and translational research. They're really enjoying understanding the life cycle of the virus and how we can hit certain enzymes or how we can target things to try to change it. So I think it's going to cause a sort of a renaissance of research among our junior faculty, because I think that's going to be true going forward. And finally, I think many of our clinicians are realizing that their voice is very respected and well heard in their communities. So that many of our doctors have gone out in their community meetings, in their education boards, to talk about the importance of mitigating this virus and how they need to be involved more in politics. And as you said, I think one of our biggest failures was the lack of a central governmental approach to how to deal with this. Giving each state their own free will, I think, really set us back on what we could have done. So I think understanding how physicians need to get more in the political arena and make an impact on the communities is a third thing that'll come out of this.
Great, thank you. Adrian.
I think the one thing that hasn't been mentioned yet that I would sort of throw into this, and I echo a lot of what others have said, is that one of the next things that is going to be upon us is the flu season. And that is going to confound and augment what is going on with COVID. And I'm really hoping that sort of at both, all of our local levels, as well as sort of with our, public health departments and beyond, we're able to sort of leverage everything we've just talked about to sort of mitigate as much as possible the impact of, a flu season on top of a potential fall COVID surge, and would just encourage everyone to begin thinking along those lines. And we've started, planning here for both and integrating the planning. So I would just sort of throw that into the mix as something for all of us to be thinking about right now.
Great, thank you. I don't know if George is still on. If he
Yeah.
is, I'd love to hear if he has a last word. You spend a lot of the time looking at the numbers and the graphs, but sort of hearing vividly what's going on at all these places. Any additional thoughts you want to have? And if somebody can turn on George's video, that would be fantastic. But if not,
Hi.
there you go. Go ahead.
So, I can't agree with I agree with what everyone said. I'm concerned about person power. I'm concerned about burnout. I'm concerned about mental health. That's all, that's all downside. The upside is that we're entering a new golden age of public health where all of a sudden everybody gets it. I can tell you that having to do, I have a meeting with all fourth-year medical, I have a mandatory meeting, not my idea, with all fourth-year medical students interested in careers in public health, in which the grand turnout is usually 0. There were 17 this year. And I was flabbergasted. So I think the good news is that we're going to have some renewed interest in public health. And with renewed interest in public health and this experience, maybe we'll be able to turn it around like South Korea did after MERS, where they basically increased the public health workforce tenfold so they wouldn't get burned again.
Well, let us hope.
That'll happen.
As George knows, my best friend, who's an avid watcher of these, wants to name his new grandchild George. So that just is a metric of, and you're voting for it. It's a metric of how much I think we've all come to understand what public health is about and epidemiology is about in ways that we didn't before, and how incredibly vital it is. Let me thank all of you for a really interesting session and for sharing with us and for doing everything you're doing. I have to say, like Adrian, we feel like we're having a surge, but we're also, we're seeing little ripples compared to what you're all dealing with, and we will just hope that we don't get there. But thank you for doing what you're doing and taking care of the patients and helping us all figure this out. So we will sign off now. Thank you for all joining us. Let me thank our production team, who is shown on the screen, who do a great job putting this up every week. We'll be back again next Thursday with another Grand Rounds. I'm not sure about what yet, but there's plenty to talk about. And this will be up on YouTube at about 7:30 tonight, and I will tweet out the address. So thanks for joining us, and stay safe out there.